Hello, and thank you for watching the basic level of the toxicology curriculum. This is a collaboration between McMaster University, Western University, and the University of British Columbia. This basic level theme is about toxidromes. By the end of the series of sessions on toxidromes, you should be able to identify the major toxidromes, to describe the characteristics and pathophysiology of these poisonings, and to give examples of substances that can cause these toxidromes. Let's start with a definition. The term toxidrome comes from the words toxic syndrome and refers to a constellation of vital signs and physical findings that are characteristic of certain ingestions, exposures, or withdrawal of ingested substances. These clinical syndromes are essential for the successful recognition of poisoning patterns and are frequently used clinically. The recognition of a toxidrome is useful for several reasons. It can help to suggest which investigations would be useful to evaluate the patient. It can also help to guide the type of therapy and potential antidotes that may be appropriate for the patient, as well as to predict the response to therapy and outcome. It is, however, important to remember that toxidromes only describe the classic features of a type of poisoning. Actual clinical cases may be more variable and only show partial manifestations or a combination of toxidromes, especially in the context of mixed ingestions. At the same time, knowing the classic features of a toxidrome can be useful to identify if the clinical features are consistent with the history of ingestion or the suspected toxin. There are 5 classic toxidromes: anticholinergic, cholinergic, sympathomimetic, opioid, and sedative hypnotic. There are also characteristic withdrawal syndromes from opioids, sedative hypnotics, and ethanol that are clinically useful. Let's move on to a case. This is a 16-year-old male who was found running naked through a field. He was found to be agitated, combative, and actively hallucinating. His pupils were widely dilated with a heart rate of 130 beats per minute, blood pressure 160/95, respiratory rate of 20, and temperature of 39. His speech was difficult to understand as his mouth seemed very dry. What toxidrome is this? And think about the types of exposures that could produce this clinical presentation. This case is a classic example of an anticholinergic toxidrome. This saying is often used to remember the features of muscarinic receptor blockade that is seen with anticholinergic exposures. Hot as a hare, dry as a bone, red as a beet, mad as a hatter, blind as a bat, and full as a flask, meaning that the patient is hyperthermic, has dry skin and mucous membranes, is flushed, hallucinating, has dilated pupils, and urinary retention. Other features include decreased bowel sounds, tachycardia, with or without hypertension. Atropine is the classic anticholinergic drug. However, this toxidrome can also be produced from a number of other medications and exposures, including tricyclic antidepressants, antihistamines, antipsychotics, muscle relaxants, mushrooms such as Amanita muscaria, and plant sources such as Datura species or Jimson weed. This is a case of a 54-year-old man brought to the emergency department following the ingestion of an unknown liquid. His heart rate was 130 beats per minute, blood pressure 90/50, respiratory rate 36, oxygen saturation 76% on room air, and pupils 3 millimeters. There were several unsuccessful attempts at intubation en route to hospital because of the excessive amount of secretions. He arrived very wheezy with the nasal cannula in place. He was also noted to be diaphoretic and had an episode of diarrhea in the emergency department. What toxidrome is this, and what types of exposures could produce this clinical picture? This case is an example of the cholinergic toxidrome, which occurs because the neurotransmitter acetylcholine cannot be broken down. Acetylcholine binds to both the pre- and postgangliotic receptors and can produce both muscarinic and nicotine effects. Stimulation of the postgangliotic receptors gives the typical parasympathetic or muscarinic toxidrome, which can be remembered using the dumbbells mnemonic. There is one muscarinic sympathetic acetylcholine receptor on the sweat gland that produces the excessive sweating. Acetylcholine is the major neurotransmitter for the preganglionic sympathetic nervous system, which are nicotinic acetylcholine receptors. That is why it's possible to see sympathetic symptoms as part of the cholinergic toxidrome. Nicotinic acetylcholine receptors are also responsible for the excitation-contraction coupling in the voluntary nervous system that can produce muscle fasciculations and cramps with acetylcholine excess. These nicotinic effects can be remembered using the match mnemonic. Examples of exposures that can produce a cholinergic toxidrome include nerve gases such as sarin, pesticides including carbamates and organophosphates, as well as some mushrooms. The other classic toxidromes will be discussed further in the following sections, but are summarized in this table. In addition to the classic toxidromes already mentioned, there are also other groups of toxins that can produce characteristic toxic syndromes. These include the slow and low toxidrome produced by a number of cardiotoxins. There will be a separate section discussing this toxic syndrome further. Others include exposure to hallucinogens, caustic substances, exposures that produce hemoglobinopathies, and metal fume fever, which typically is an occupational exposure to welding fumes. Here are some further questions to think about. Number 1. Describe the innervation of the parasympathetic and sympathetic nervous systems and how it relates to the toxidromes we've discussed. Number 2. What antidotes can be considered for the anticholinergic and cholinergic toxidromes?